All right. So the time is 7:04 p.m. So I think we'll go ahead and start in the interest of time, as is always the case. So good evening, everyone. We are very glad to have you today once more for our once more for one of our Life is Why campaign CMEs. So we'll go ahead and start with a brief introduction for those who are new to quality care. Just to tell you a bit about quality care, who we are, what we do, and then after that, we'll go ahead and dive into today's course content. All right. So Quality Care is an international training center. For quality care, our main focus is emergency care. So we train courses like basic life support, we train advanced cardiac life support, we train pediatric advanced life support, we train pre-hospital trauma life support, we train point of care ultrasound training. Soon we'll be training critical care. Um, Yes, so we welcome you. Welcome you. Apart from attending our CMEs, we hope that it lights a fire in your belly for the purpose of gaining knowledge and skills, so that you can actually come and train and get this knowledge as the whole package, not just as bits and pieces. So for the purposes of today's CME, we'll have Edna. Edna will be taking us through the CME session today. Edna is an AHA instructor. She's also a point of care ultrasound instructor. She's also a critical care instructor, and she works in the ICU. So in terms of knowledge, she has a wealth of knowledge for us today. In terms of location, this is where we are based. Personally, I know majority of us usually attend the CMEs for the for the purposes of the CPD points, but we hope with time you actually get the knowledge and the skills, and it actually makes an impact when it comes to your practice, so that wherever you are, you're able to improve the quality of emergency care that you offer to your patients. Now, in terms of location, this is important specifically for clinical officers. So clinical officers, in order to claim CPD points, as always, you have to come physically to our offices at Fifth Avenue Suites. This is along Gong Road, 8th floor at Quality Care. So if you haven't been here before, I'll share the link or maybe a pin to our location in the chat box. So please keep it safe. Recently, we've been getting many clinical officers coming. So don't be left behind and come and have your logbook stamped. That is for clinical officers. Medical officers, you're more lucky because the process of claiming CPD points isn't hard. So we'll share CPD claim cards to you via WhatsApp. This should be not tomorrow. Let me not say tomorrow. So next week on Tuesday, because Monday itakuwa sabasaba. Monday itakuwa sabasaba, so hatutakuwa kazi. But on Tuesday, we will share your CPD points. For nursing officers, similarly, you get a certificate. So after today's CME, you'll get a certificate on Tuesday, which you'll be able to upload in the NCK portal, and therefore you'll be able to claim your CPD points as well as a result. So as quality care, we're still doing the Life is Why campaign. Today we were in Comarock, preaching the gospel of high quality CPR. In case you're working in a hospital where possibly people do not know about high quality CPR, I would encourage you to invite us to come and speak on the importance of high quality CPR. Today's focus is on vents, but whenever we get a chance, we always speak about this because our main focus as quality care is basic life support. Strongly believe that everyone should have trained in basic life support, medical, non-medical staff. Most cardiac arrests happen at home. It's the number one killer of both men and women globally. So knowing how to do high quality CPR is very, very important. If your patient doesn't have a pulse, they're unresponsive, they don't have a pulse, you need to initiate CPR immediately, not only CPR, but high quality CPR. If you do not, 7 to 10% chances of survival for your patient is gone for every minute that goes by. So, in a nutshell, this is the Life is Why campaign. We try and sensitize medics on the importance of initiating high quality CPR as soon as possible, as well as early defibrillation. Without the two, your patient will lose. So in case you're working in a place where they would need information on the same, please don't hesitate to invite us. We will come and do a CME on the same. Having that in mind, we've been traveling county to county, doing basic life support, advanced cardiac life support training. No different in July. July tutakuwa Eldoret next week, same to Kisumu, Nakuru, Malindi, Mombasa, and Machakos. In case you or a friend or a colleague, your certificate has expired, perhaps you want to gain knowledge and skills, then we encourage you to register by latest Saturday, which is 5th July, so that you can get your books for reading, uanze kusoma, so that by the time we start the class, you are 100% prepared. So apart from that, we also offer a number of courses. As I mentioned, point of care ultrasound, pre-hospital trauma life support. We actually had a training today, pre-hospital trauma life support for the medic who would want to work in the pre-hospital setup. As medics, we have so many options. You don't necessarily have to be looking for jobs in hospital, just looking for 9 to 5s, looking for locums here and there. You can become an instructor. You can work in the pre-hospital setup, which looks like becoming a flight doctor for AMREF, becoming a flight nurse for AMREF, possibly working in those cruise ships which go out for vacation. They need medics on board, but of course, you must have the necessary certification. Yeah, so many options. You just have to make use of them. We also have pediatric advanced life support. This is for the medic who deals with the peds population. Super, super important. It is rare for the peds population to enter cardiac arrest, but when it does happen, it will be the difference between saving or not saving a patient's life, the knowledge and the skills that you get in the pediatric advanced life support training if you deal with the children. Super, super important if you deal with the children. Next week, we'll be having a point of care ultrasound training. Here we'll be doing vascular access. This is the previous class. So point of care ultrasound training, personal feel, will revolutionize how we assess patients, because you know it's on the spot. You just have your web probe, you have your tablet or your smartphone, hook it up, you have your ultrasound gel, Scan the patient, come to a clinical decision, and then manage your patient based on what you. So point of care ultrasound training is great. Here we are doing vascular access. You can't seem to find the vein. Voila, just like magic. You see it over there. To encourage you to also consider training in point of care ultrasound training. Here we are doing lung ultrasound. Here we are doing high quality CPR somewhere in the bush. Soldiers are doing training on how to do it. Everyone should know how to do high quality CPR. On the left, basic life support. On the right, advanced cardiac life support. Here, we're practicing how to extricate a patient. Specifically, this is pre-hospital trauma life support. The most damage which is done to a patient in an accident is actually done after the accident occurs, because no one stabilizes the patient, their spine, their neck. Mtu tu anabebwa, anaingishwa kwa gari, anapelekwa hospitali. And in doing so, you do more damage than do to this patient. So in case you know a friend or a colleague who already works in the pre-hospital setup, but does not have these skills, very important for them to train. We have a number of partnerships, MSSI, Avant, for nurses who are trying to go abroad. We refer nurses to Avant, who then process your relocation to for greener pastures. But of course, you must have done and passed your NCLEX as well as met a number of requirements. If you're a nurse or know a nurse who wants to go abroad, please get in touch to idea. Yes, we have also partnered with GASI, which is Global Ultrasound Institute. Certification for point of care ultrasound comes from them, internationally recognized as well. Yes. Having said that, I want to leave it there. We have a number of courses. We have focus starting next week. We have, well, this is BLS, ACLS in Tumutumu. We have a training there. We also have a BLS, ACLS training next week in Nairobi. I'll share all of these information in the chat box. In case you're interested, tunakukaribisha sana. Now, on to the business of today. Today we'll be discussing vent use. We'll be having Edna taking us through the session. So yes, a few videos will play. We had a vent, but yes, we wanted to show you the vent physically here, but yeah, unfortunately it was being used. So we recorded a few videos which we'll have a look at after the discussion. So first we'll have a discussion on vent use, and then after the discussion, then we'll watch the videos, which will hopefully help us gain more understanding on how to use them. So without further ado, I want to welcome Edna. Thank you very much, everyone, for joining us again today. We are very glad to have you. Thank you.
Hello. Hey, good evening. My name is Edna. I want to welcome you to this CME this evening. I will be talking about basics of ventilators, just the basics. We are not going so deep. Edna is a part of quality care faculty. I'm a trainer with American Heart. I do trainings for focus. I also am an emergency and critical care technician working in ICU. And today we'll be talking about the basics of ventilator. So when you see a ventilator, what do I want to set? What do I want to look for? Which mode do I want to prefer for which patients? And what is the type of the breath that I want to give to the patient? So let's start with that. So when I'm doing a mechanical ventilator, when I'm doing my mechanical ventilation, this is for patients who have respiratory issues, or the patient that have very low GCS, that you require them to be on assisted mechanical ventilation. And the patients can be intubated, or the patient can have an advanced airway or no advanced airway. So it can be invasive or non-invasive mechanical ventilation. So we start with the settings that I want to set for these patients. And for settings, we have the major settings. So we have the major settings. And then we have universal settings. And we have other settings. So let's start with universal settings. And for universal settings, these are settings that cut across all the modes of mechanical ventilation. So for every patient that is on mechanical ventilation, these are the settings that they must have. And we have two universal settings, that is the FiO2. FiO2 is the fraction of inspired oxygen. That is the concentration of oxygen that you want to give to these patients. Normally in a room air, our FiO2 is 21%. So when a patient is on mechanical ventilation, the FiO2 you can start with something like 60 to 80. Sometimes you can go all the way to 100%. And as the patient improves, you want to reduce your FiO2 because this is the concentration of oxygen. Within 24 hours, your target goal should be less than 60% of the FiO2 because you do not want to give your patients oxygen toxicity. So that is the first universal setting. The other setting that you want to set for any patient on mechanical ventilation is something we call the PEEP. And PEEP is the positive end expiratory pressure. And the positive end expiratory pressure is the pressure at the alveoli when someone breathes out. This is the pressure that is preventing the alveoli from collapsing when someone breathes out, because we don't want the lungs collapse when you breathe out. So the normal PEEP is 4 to 5 centimeters of water. So that's the normal PEEP. So for any patients that you want to to put on a mechanical ventilation, you have to put at least the normal PEEP. So depending on the condition of the patient, you want to either increase the PEEP or slightly reduce the PEEP. Those are the universal settings. Now let's talk about major settings. The major settings that we are going to put on these patients. And for major settings, we have one, tidal volume. Sorry, my voice is breaking. I hope it's okay now. Okay, so we have the major settings, and the major settings that we have, one is the tidal volume, and the tidal volume is when you're cycling volume. So you can either cycle volume or pressure control. This, we call them the breath types. So if I decide to cycle volume, you can either cycle volume or pressure. If I decide to cycle volume, I have decided that I'm going to give this patient this volume. And then the ventilator is going to decide the pressure that it's going to use to ensure to achieve the volume that has been set. If I decide I will cycle pressure, I set a constant pressure and the ventilator will decide the volume that it's going to give with that pressure. Now, we have the advantages and disadvantages of using this. For example, if you have volume, this is the most commonly used cycle method or the breath type. And when you have patient with compromised alveoli, like for example, where we have ARDS, this can easily cause injury to the alveoli, something that we call barotrauma. So the most preferred way to cycle the breath is by giving pressure. Pressure also is a very good cycle breath type when I have compromised lung. For example, if I have ARDS, I can decide to give pressure. So because this one is going to decide the volume. If my lungs are compromised, you don't have to give a lot of volume. However, if I have a patient with secretions or there's the tube has kinked, there's dislodgements. Now, what happens is because with the pressure that I've set, the ventilator decides the volume. What happens is the patient is going to have less volume. So we are going to give this patient acidosis because there's accumulation of a lot of CO2. So those are the major settings. So we have tidal volume or pressure control. The other thing we set in the major setting is the respiratory rate. So for example, if I am having a patient who I need to give assist control, where the patient, they are not having spontaneous breath, I need to give the respirator to set the respiratory rate that the machine is going to give these patients. However, if the patient is on spontaneous mode, that one, it will be determined by the patient. Another thing that is in major settings is the pressure support. The pressure support now comes in when the patient has spontaneous breath, and I need to support the spontaneous breath of this person. Now, there's a difference between pressure support and pressure cycle, and you'll see the difference. So that is for major settings. Other settings that we want to do is one, the IE ratio. And the IE ratio is the inspiratory and expiratory time. Let's say, for example, I have set my respiratory rate at 20. So in a minute, between breath to breath, I'm using 3 seconds. So in these 3 seconds that I'm using to have one breath, I need to decide how much time do I use for that the patient use to inspire, and how much time do they use to expire. Now, this one will vary from patient to patient, depending on the condition of the patient. For example, an asthmatic patient or a COPD patient, you want them to use more time to expire and less time to inspire. So your IE ratio will be more on the expiratory than the inspiratory. For a patient with compromised lungs, for example, in ARDS, you want them to use more time when they inspire than they use to expire. So that one is one thing that you want to set in your ventilator. Something else we want to set is the flow pattern. And this is the pattern that we use to deliver the air that is coming. In the flow pattern, what we are delivering is the flow rate. And the flow rate is the speed by which you want to deliver this air. For example, do you want to deliver it by 60 liters per minute, 40 liters per minute? That is what you're going to set. And the pattern that you want it to come into. Is it a decelerating curve or is it a square? So all these, we are going to see them in the ventilator when we set them. The other setting we want to do in other setting is sensitivity. So sensitivity is the trigger, how the patient or how the machine will be triggered to give a breath. And we either set a flow trigger or a pressure trigger. This is when the machine is going to determine, oh, it's time to give a breath. So it drops, whether you set the pressure, it's going to drop the pressure by a certain number, then that prompts the ventilator to give a breath. If it's the flow, it alters the flow by dropping it, and this tells the machine it's time to give a breath. So that is for other settings. Now let's go to the types of modes that we use in our ventilator. We have very many modes, but the most commonly used modes are three that we are going to discuss about. And that is the assist control, we have the synchronized intermittent mandatory ventilation, and then we have the spontaneous mode. Okay, let's talk about these modes and when do I set these modes. Let's start with assist control. So assist control, in some ventilators, they might call it control mandatory ventilation. And from the name, what is happening that the machine is controlling every breath that this patient has to get. So there's full control. So what do we set for this mode? Again, we start with the universal setting. We are going to set the PIP, that is mandatory, and we are going to set the FI rating. For the major settings, we are going to set either tidal volume or the pressure cycle. So this one you're going to decide depending on your patient. If I decide to give the tidal volume, I give 6 to 8 mils per ideal body weight. For pressure cycle, you can give anything from 8 to 20, depending on your patient. So that's another thing that you're going to set. The other thing you want to set is the respiratory rate. Again, these patients, mostly if you want to put on assist control, because you want to control everything, this might be a patient who is paralyzed or sedated. These are patients who might not have efforts to breathe. So these are patients you want to set the normal respiratory rates. So you can set anything from 10 to 20. For other settings that you want to set, the other setting that you want to set for this patient, you want to set the sensitivity. The flow rate, the flow pattern, and the IE ratio. So that's for the settings of assist control. Now, what happens if the patient wakes up and let's say, for example, you set a respiratory rate of 10 and the patient wakes up and they make extra 6 breaths. So for those extra 6 breaths, whatever you set, if you set a tidal volume of 400, an FiO2 of 100, a PEEP of 5, whatever you set, that will be given to the patient. So there's no difference between the vents generated breath and the patient's generated breath. They are all equal. The volume is the same, and if it's volume or the pressure is the same. So for this one, if our patient is awake, what happens is they are going to have more volume. This can lead to respiratory alkalosis. So in case your patient was totally sedated or they were paralyzed and now they are recovering and they are waking up, now you want to change your mechanical, to change your mode to another mode that is, we can use it for weaning off, and this is the synchronized intermittent mandatory ventilation, known as SIMV. Some machine might call it the IMV. And what this is doing is you're going to set one, the universal setting, the remain, the PEEP, and the FiO2. For the major setting, you're going to set your tidal volume or the pressure cycle. You're going to set your respiratory rates. And in this one, you're also going to set the pressure support. So now this pressure support is for that breath that is generated by the patient. So in case the patient decides the machine is giving me 10 respiratory rates per minute, but the patient decides to add 6. So for those 6 that are generated by the patient, the patient decides the volume that will be given. That depends on the effort of the patient. But what the machine does is it supports that breath that is generated by the patient. So we are going to set something we call pressure support to support the spontaneous breath. For other settings, you're going to set, again, the sensitivity, the flow rates, the pattern, the flow pattern, and the IE ratio. And this one mostly will apply to these ones will apply to the breaths that are given by the mechanical ventilator. So there's a difference between the assist control ventilation and the synchronized intermittent mandatory ventilator. This one, mostly it's used for weaning off patients. Now, the last mode that is commonly used and I would like to discuss about is the spontaneous mode. So for the spontaneous mode, for ventilators, we are going to see them known as the pressure supports, called the pressure support ventilation or the CPAP. That's what most ventilators will call it. Now, in this mode, what is happening is it's actually the final mode that we want to put to the patient before we completely wean off this patient from mechanical ventilation. So if you want to extubate, if the patient was extubated, or now you want to stop the mechanical ventilation and go to the normal oxygen. So what is happening in this mode is the patient does everything. So the patient is the one that is generating the breaths. So they are the ones to decide the respiratory rates. They are the ones to decide the pressure that they are going to use, and they are the ones that are going to decide the volume that is getting in the lungs. So what do we set for the spontaneous mode? So what we set in the spontaneous mode Again, universal setting, we are going to set the P, that is the positive end expiratory pressure, and the FiO2, the concentration of oxygen. Then what we are going to set is the pressure support. So for these breaths that are generated by the patient, I want to support the breath. So you can set a pressure support of 10, 12, 15, depending on your patient. Then as you win up your mechanical ventilation, you want to go as you reduce your pressure support and see how the patient performs before you decide to fully discontinue mechanical ventilation. So those are the 3 commonly used modes of ventilation. Now, you put your patient on a mechanical ventilator, and what do I monitor for? The first thing you want to monitor for is the peak inspiratory pressure. And the peak inspiratory pressure is the pressure that is in the airway. And that means from the tubings, from the ventilator, all the way to the bronchi. So you want to set it less than 35. So if you see your ventilators, at the ventilator, it's known as the P peak. So if you see your ventilator is alarming and the P peak is more than 35, you want to ask yourself, are there secretions? Is there any obstruction? As the tube dislodged, do I have pneumothorax? So these ones are what are going to be affected. Something else that you're going to set in your mechanical ventilator is your alarms. When does it alert me if there's an issue? So what you're setting in your alarms is how much volume do you want, the maximum volume in case the patient is adding on the volume if they have spontaneous breath, the maximum you want them to go, and the minimum that you want them to go. Also for patients who are on a spontaneous mode, what is the respiratory rate that they have to give? Those are the things that you set in the alarm. The other thing you want to be monitoring is your minutes ventilation. Minutes ventilation is the volume that a patient gets per minute. And the minute ventilation is simply the tidal volume times the respiratory rate. Also, as you set in the alarms, what is the minute ventilation, the maximum that you want them to have, and the minimum that you want them to have. Those are the things that you want to monitor in a mechanical ventilator. So for today, that's what we are going to be discussing. Let's watch what we are looking for in a mechanical ventilator and how a mechanical ventilator looks like, what to set. Okay, we are about to watch a mechanical ventilator, how it looks like, how to connect to the oxygen port, and how to set the settings that we have talked about. So let's watch the video. So here with me, I have the mechanical ventilator, and what I'm using today is the mid-rate mechanical ventilator. Okay, so here with me, I have the mechanical ventilator, and what I'm using today is the mid-rate mechanical ventilator. We have several types of mechanical ventilators. So the first thing I want to do is these are ports to connect to oxygen. I want to connect my to oxygen port. Then switch on So in these parts, it's talking about system self-tests, which has been done and it has passed. So if it has not passed the system self-check, do not use that ventilator. So mine has passed, so I will skip that part. Then here, what I have is you have to decide whether it's the last patient that you want to connect to the mechanical ventilator. Is it a new patient or is it a new pediatric? So for me, I will choose the new patient. You asked whether it's male or female. So it's female. Then the next thing you need to choose is it invasive ventilation or non-invasive? This means, does your patient have advanced airway, or are you using the mask, that is the non-invasive? So we can choose invasive. Then the next thing we want to do is calculate the ideal body weight, because when we are choosing our volume, we will be using the ideal body weight. So for ideal body weight, for us to calculate the ideal body weight, we need to have the height of the patient, and the machine will calculate for us the ideal body weight. So I can choose my patient has an ideal body weight of 156 centimeters. Then you enter, and what does it calculate? The ideal body weight of that patient. Then now we proceed to the modes that we want to set for our patient. It's a Mindray ventilator, and the first thing you want to do is connect your ventilator to oxygen port. Then switch on your ventilator. So before you start using your ventilator, you should do a system self-check, which already has been done to our ventilator. Then now we are going to discuss about the different modes of ventilator and what we set for every mode. So with me, I have my test lung. This is like a lung. This is what we are going to be using, not a real patient. Okay, so this is our ventilator, and down here we have the modes of ventilation and the settings that we are going to be using. To begin with, we have our AC mode, that is assist control, and we have assist control volume cycle. So the first thing you want to set is your FiO2. We've talked about the FiO2, and the FiO2 is the concentration of oxygen. The normal FiO2
that is room air, is 21, but for a ventilated patient, you want to increase that. So I can start with 80%. The next thing, because it's volume cycle, I want to set the volume that I want the patient to have. And the volume, we set 8 mils per kg, assuming my patient is ideal body weight. My patient's ideal body weight is 50, so 8 times 50 will be 400. So I'm going to set at 400. Then next, I want to set my respiratory rate, and you can choose the respiratory rate that you want to choose. I can choose to have 14. The next thing I want to set in this is the inspiratory time. So this one you can choose. If I have set 12, or let's say we've set 10, so between breath to breath we have 6 seconds. So you can choose how many seconds you want them to take when they are taking in the breath. How many seconds do they take when they are taking out the breath? That is the time that we set here. And that will be dependent on the condition of the patient and other settings. The other thing is the PEEP, that is the positive expiratory and expiratory pressure. The normal PEEP of a patient is 5. So depending on your patient, you want to at least have the normal PEEP. So assist control is on. The next thing is the trigger, the sensitivity of the patient to give, and the sensitivity that you're going to set so that it triggers the ventilator to give a breath. Then after that, you can now start your ventilation. So we've begun our ventilation. So when we begin our ventilation, we notice there are 3 curves on the left side of our ventilator, and we have some parameters that we are going to be monitoring on this other side. So the first curve is for the pressure. That is the pressure that is being used to deliver the volume that we picked for our patients. The next thing is the flow rate. That is the flow by which the volume that we are giving is being delivered. Then the last one is the volume that is being inspired. That is what we have here. Then on this other side, what we have is first the P peak, that is the pressure, and this pressure is the pressure from the tubings all the way to before we get to the alveoli. So the normal peak pressure should be less than 30. So if we have high peak pressures, we want to think about secretions, we want to think about our tube being dislodged, or if there's any obstruction. The other thing we have down here is our minute ventilation, and the minute ventilation is the respiratory rate times the tidal volume. This is the tidal volume that our patient is making. Then it tells us about the FiO2 and what we are giving to our patient per minute. So that is for AC volume cycle. So we have also AC assist control pressure cycle, and what will be given, the type of breath in this case will be a pressure control. So what I'll be setting is, again, the universal setting. I'm setting I will be setting my FiO2, I'm setting my PEEP, my respiratory rate, the time of inspiratory, the trigger, the slope, and then instead of setting the volume, the tidal volume in this case, what we will be setting will be the pressure. So what we are cycling in this mode is the pressure. Is the pressure, and then what it gives us is the volume. Then we have other
Okay, so I want to apologize about the quality. I just noticed the quality is not the same. Those are recorded videos. So we will share the videos on our YouTube channel tomorrow. We will share the link. So at this time, I want to take any questions on basics of mechanical ventilation. Please share your questions in the chat box. It's Quality Care Kenya. The person asking what is our YouTube channel called? It's Quality Care Kenya. So can't see any other question. So I will invite Edgar to come and end the CME. Thank you.
All right. So thank you very much, Edna, for that very detailed presentation. So we have come to the end of today's CME session. I can see there are a few questions on the chat. Uh, Unfortunately for today, we've run out of time. Robin is asking about the different modes of mechanical ventilation. I know it's a topic we want to enter into, but it's a broad topic that we wouldn't be able to elaborate on right now. But there are a few videos that we did with the vents. I know it didn't come out clearly on the Zoom. It didn't come out clearly via Zoom, but the actual videos will be able to take you step by step on the actual use of events. We'll post those videos tomorrow on YouTube, and then we'll share those videos, and hopefully they will enhance your use of your event. Yes, they're very detailed, step to step and step by step, and you'll be able to see the settings clearly. Having said that, I want to say a big thank you to all of you for attending today's CME. CPD points, we'll share them next week on Tuesday. So these are for medical officers, nursing officers, and clinical officers. Medical officers, you get a CPD claim card. Nursing officers, you get a certificate which you upload via NCK. And clinical officers, of course, you'd have to bring your logbook to be stamped at our office. So for those who joined in a bit late, let me just share my screen. This is where we're located. We're located at Fifth Avenue, Singlewood. So for your CPD points for clinical officers, you would bring them to be stamped over here. This is where we are based. Just a reminder, we have a number of courses. These ones for July. We have POCUS next week. We have BLS, ACLS from 11th to 13th of July. We have pre-hospital trauma life support from 17th to 18th of July. So we encourage you to register and come and train with us. Thanks so much for attending today. We'll share the recording for today's session via email tomorrow as well as the detailed videos on how to use the vent physically. Because it's nice to know it theoretically, but also I'm sure the videos will help you a lot in trying to do so. So thank you so much. I want to call it a day. Time is 8 p.m. Have a great evening and see you in the next CME. Good night.